First, thank you, Robin, for being so kind. And in many ways, coming back to CVRTI and Salt Lake City, where I spent a few visits, and some of them collaborated visits with Dr. Rudy who was here. It feels in many ways, you'll see in the talk, it feels in many ways as homecoming for me. And I really appreciate both the invitation and also the really outstanding and warm hospitality of all of you. It's been very, very nice. And I'm having a great time. Thank you. So this talk is a little different from talks that I used to give. I always used to talk about the latest work in the lab and the forefront of research and so on. But what I try to do for this talk is to make it into a didactic lecture on conduction, using work that was done in the lab as supporting evidence and as bringing out principles related to the conduction of the cardiac impulse, cardiac echo potential in the heart. So we all know, we all know that cardiac tissue is really not one big pie. It's composed of small cells that are 100 microns in length, roughly, and 10 microns in diameter. And these cells are connected to each other, but under normal conditions, the action potential is conducted and travels through this system that is a complicated system of many different individual cells, as if it were a continuous syncytium. It looks functionally to propagate smoothly in syncytium rather than in such a discrete structure. The question is, how is it done?
I'm trying to create a light show. I'm trying to be subtle and just turn down the front light. I want to tell you, have to kick me out. That's what you do. Yeah.
Great, thank you. Everybody can see it. So yeah, just to repeat, the structure of the system is many discrete cells, but action potential propagation that is really essential for coordinating contraction in cardiac muscle doesn't really see the discrete structure on a global scale. It looks as if it were one big pie. And the question, how is that possible and what is the mechanism? Okay, there are many theories. Some theories suppose early on that it was one big pie. Then there was a theory that said conduction between cells is through chemical mediation, just like in the nervous system. And it was not clear what was going on and how conduction is accomplished. So, some history. You cannot really talk about conduction and gap junction. You cannot really talk about conduction and gap junctions in the heart and the connection between cells without bringing Silvio Weidman. Silvio was later on in life, he became the chancellor of the University of Bern. Before that, he established a fantastic physiology institute in Bern that became world renowned and really did many of the pioneering studies and pioneered modern cardiac electrophysiology. In many ways, Silvio Weidman was the father of modern electrophysiology in the heart. And Silvio spent time as a postdoc. This is for the postdocs among you. He found a good lab. As I said, to follow Hutchin and Huxley while getting ready for the expedition to Plymouth, to look over their shoulders while working there and to listen to their discussion on how far they should stick out their necks in attaching physical meaning to their formalism were invaluable lessons for me. So Sylvia was there at the time that Hodgkin actually did the Nobel laureate work on conduction and on the giant action of the squid, which, as you know, changed the face of physiology as we know it today. So he was there at that time, learned the techniques, learned how to make microelectrodes, and was the first person to record the cardiac action. Yeah. He was a master experimentalist. I also liked him personally because he was a wise man and had a great sense of humor, very incisive, sometimes some sort of penetrating sense of humor, similar, in my view, to Mark Twain. So he was a really wonderful person to be with, and a very wise man. So anyway, Weidmann devised the following experiment. He asked the same question: how does the action potential travel in this great system of cells? So what he did, he took cardiac tissue and divided it by partitions and inject from one end thyroid solution of labeled potassium, radioactively labeled potassium. So he can really measure the profile of potassium that was entered here all the way to the exit. And so he had a function that told him how much potassium was at every distance. And you see here with the appendix by Hodgkin. Hodgkin is the Hodgkin of Hodgkin and Huxley, who was a quantitative person in Cambridge. All the postdoc happened in Cambridge. And Silvio did the experiment. He was a master experimentalist, very creative, but he really couldn't do the analysis. So a lot of people ask why the paper has the statement with addition from Hodgkin. So here is the answer. Weidmann said, I never felt at ease with mathematics. I still belong to a group of individuals who have reasonably good intuition, but are unable to describe results in terms of equations. So he was aware of those limitations and asked help from Hodgkin and was not ashamed to say it. And tongue in cheek, it's through science that we prove, but through intuition we discover it. So it's a beautiful state. So these are the results with the quantitative analysis from Hodgkin. You can see the profile of potassium concentration as it goes through the system. Okay, this is the mathematical expression that you can see here in the solid line among the experimentally measured dots. And what you should take home as a message is the finding that lambda, the critical length, that tells you how far cells communicate in terms of potassium diffusion, how far was 1.55 millimeter. That's a very important finding because it's 12 cells, meaning that there is diffusion from cell to cell, and it's possible to conduct current by using potassium ions from cell to cell. And in fact, it's a long distance. It's 12 cells that communicate electrically. Okay. So in conclusion, the intercalated disc, which is the structure that connects to cell, separates to cell, offers low resistance to the movement of potassium ions. The permeability of intercalated disc to potassium is 5 times greater than that of the cell membrane. So compared to the cell membrane, we have low resistant pathways connecting cells. And that was an important finding that Weidmann established with this experiment. So Weidmann went ahead and structured the following principles that he stated. That is, that cardiac tissue is made up of isolated cells. We knew that cells communicate electrically and work together, forming a functional syncytium. So it's not a structural syncytium, okay, but it's a functional syncytium as far as current flow And the communication is through the low resistance pathways at the intercalated discs. He then used scientific imagination to predict that the intercalated disc supports a structure that provides for low resistance pathways between cells. Propagation of the cardiac action potential is possible by local circuit currents, so there is no need for chemical mediation between cells like in the nervous system. In other words, Sylvia Wyman imagined the existence of gap junctions in the absence of any structural evidence. Remember, he did all of this before we had all the knowledge that we have now about the gap junctions and their structure, and with Robin work about how they get there to the intercalated disc. We know a lot about gap junctions, but early on that was not known. So I'll show you what was known early on gap junction structure. And this is from early experiments of what's called freeze structure technique. You deep freeze very quickly the cells, and then they cleave and they separate at the gap between the two cells. So you can see the face of one cell of the intercalated disc. It became clear that gap junctions are channeled. There are heavy channels contributed by each cell. They come together, okay? And then molecularly, we know now that there are 6 molecular connections, 43, and all of that. But of course, this is what was known early on. Now we know that the intercalated disc is much more complicated. It has many regions, has many functions, in addition to conducting potassium through gap junctions. But for the purpose of this talk, the most important is this measurement and those experiments that were done in a preparation of cell pairs. So Robert Weingart, who was also in Bern, a lot of this work was done in Bern. The work of Robert Weingart was to isolate pairs of cells and record voltage versus current. And you can see here a beautiful IV curve. It's a straight line with the slope being the resistance. So you can think about the gap junction and the connection between cells as a resistive or conductive pathway, okay, where resistance R given by V over R, as shown by the slope of the VI curve. Okay, now comes the work that no one else but Robin Shaw did in my lab. And Robin even made the slides that you'll see now. He told me it makes him very nostalgic, but he made those slides. So what is it? We decided to have the simplest possible model that can be used to study conduction, because from, a tractable model can be very complex, but then it's not extractable. You cannot really extract principles from very complex models. The simple models have their limitations, but they allow you to draw conclusions about principles. And that, I think that was what we was after, right, Robin? Yeah, okay, he says yes. So this is the model. The model was composed of many cardiac cell models. These are model cells on a computer. And the cell that was used, the model of the cell that was used was developed by another PhD student in the lab, Qingxin Luo, who was from Taiwan originally. And he developed the model based on extensive data for the guinea pig ventricular myocyte. Okay, so it includes the different ion channels and pumps and exchangers and the sarcoplasmic reticulum and calcium cycling, all of the details of the electrophysiology and calcium cycling that the cell exhibits. And it was a lot of work, and he did a fantastic job, really, Qingxin in the lab. And this shows you the model cell and the action potential and calcium transient that it generates in compared to experiments in the guinea pig. So that chain of cells was used by Robin and some other people in the lab to study conduction and transmission from cell to cell. So first I'll show you some transmission. simulated. Again, these are all computations. You can see that under normal coupling, okay, the propagation looks uniform. The shaded is conduction between cells. Here is a conduction from point 1 to 2 within a single cell. So 1 to 2 is in the cell, 2 to 3 is across the gap junction to the next cell, and then 3 to 4 is in the second cell. It looks pretty uniform. You have to bear in mind that microscopically, this is 100 microns, and this is the order of angstroms. So microscopically, if you look, it's not continuous and uniform, but globally it's uniform. In contrast, when you have reduced conduction at the gap junctions are uncoupled, like in ischemic conditions and infarcts and so on, then the story is very different. Now the cell, okay, 1 and 2 fires as a single unit, okay, almost instantaneously. But then there is a long delay to cross from one cell to the next. So you can think about it basically as under conditions of low gap junction coupling, the cell is there to produce the action potential, but then the gap junction controls the velocity of conduction. It's a very different type of conduction than what you see here. And to show you a correspondence to experiment, this is sort of a one-dimensional, although there are many cells on each cross section, but still it's an elongated cylindrical type. This experimental thing was developed in Andre Kleber's lab together with Stefan Rohr and Jan Kuchar. Jan Kuchar was also a postdoctoral fellow in my lab. He's now in Bern, same institute. But these experiments were done in Kleber's lab in Bern. Again, we're back in Bern. And Andre developed a system where you could pattern grow cells on a substrate, and he created those one-dimensional elongated, what he called streets. Andre called them streets. And you can see the conduction. Red is this region. These are very highly well-coupled cells. And then there is some uncoupling between them and the blue cells. And you can see the delay, just like you saw in the simulation. So there is a group of cells that are tightly connected that fire almost at once, long delay, another, long delay, another, just like the simulation under condition of reduced coupling. So there are two ways to affect conduction velocity. One of them is by changing the membrane excitability. That is, membrane excitability is the available sodium channels. Sodium channel availability determines excitability, okay? So one of them is to reduce sodium channel availability or excitability, and the other is to increase the gap junction resistance or reduce gap junction coupling. Both of those will slow conduction. But there are major differences between them as far as the outcome. You can see here that when you reduce excitability, conduction velocity, shown here, is decreased monotonically and goes down to about 20 centimeters per second. 50 or 60 is normal. This is normal tissue, 60 centimeters per second. It goes down to about, let's say, 20, 15 centimeters per second, and then it drops, cannot continue to conduct. In contrast, when you reduce gap junction coupling, conduction velocity drops faster at the beginning, and then it continues to linger on and on and on, and you can achieve velocities as slow as 1 centimeter per second. And I have to tell you that velocities of 1 centimeter per second were recorded by Ursel and by people at Columbia in the healed infarction, in the dog preparation of the healed infarct. They recorded such slow conduction. So it makes sense. You know, the infarct contains islands of surviving myocardium with reduced coupling between them. So you're basically in the regime of reduced gap junction coupling. And then you can achieve, according to this theory, very slow conduction velocities as far as 1 centimeter per second. And those were actually recorded in that substrate, in the scar. And they're very important for arrhythmias because with such slow conduction, you can form very small loops of closed activity, which is known as micro reentry. Micro reentry is a very important mechanism of arrhythmias. Okay, so now Robin said we need to quantitate the robustness of conduction. And he devised this measure called the safety factor of conduction. And it's nothing else but charge balance in a cell within that fiber. What you see here is the current that is used to generate the action potential, depolarize the cell itself, and current supplied downstream to bring this cell to threshold. So there are basically two currents that are generated by the cell in question, one for its own depolarization, the other one for depolarizing the membrane downstream. It receives current from the upstream part of the fiber. So the balance of the two, and what's important is charging the membrane capacitance to threshold. So it's charge that it's important, not current. So you integrate over time, and we had some debates on what will be the time. On some drive that we had to somewhere, I forget where, we went to a meeting. Yeah, we went to a meeting, and all of a sudden, while driving and talking about it, we came to the conclusion that this should be a good integral limit. So anyway, he computed the charge for the own depolarization of the cell, the charge given to the downstream fiber, divided by what the cell receives. So if it generates greater charge than it receives, then it's safe and conduction will continue. But if the charge is diminishing and it's lower than what it receives, that means there will be gradual decrease in charge availability and conduction will decrement and fail. So this was a measure of the robustness of conduction. One is actually the limit between conduction and failure. Normal tissue with normal gap junction conductance or normal excitability, the safety factor is about 3. So conduction in the normal heart is safe with a margin. So here are some simulations related to the safety factors. First, reduce changes in membrane excitability. If you look at the right panel, you see the sodium channel availability in white, and then the rate of rise of the action potential in yellow. You see that the rate of rise of the action potential is basically determined by sodium channel availability and is a good index of excitability. When you look at the safety factor, you see similar trend. The safety factor is decreasing progressively with decrease in conduction velocity. So slow velocity to reduce membrane excitability is unsafe. It has lower safety factor than normal tissue. If you decrease excitability, you have slow velocity, you reduce the safety of conduction up to a point where it fails. The safety factor goes below 1, and this thing falls apart, and you see you can reach velocities at 15 centimeters per second, as I said. So it's not so slow. If you think about 60 as normal, 20, which is 1/3, could be also present in the normal tissue, for example, in conduction across fibers, in tissue that is anisotropic. You have faster velocity along fibers, slower transverse fiber. You can have 20 centimeters per second in normal tissue, but by reducing excitability, you're reducing the safety, and it's basically prescription for block, for failure. not for very slow conduction. This is just a comparison to experiment. The experiment is the effects of ischemia, which is reduced sodium channel availability. Ischemia is causing reduced excitability, mostly by increasing extracellular potassium, which depolarizes the membrane, okay? And in addition, what you see here are two curves. The yellow is just the effects of increased extracellular potassium on conduction, and the green is with the added effect of acidosis. But focus on the yellow one, which is extracellular potassium changes. With ischemia, extracellular potassium is increasing. As it increases, first, you see augmentation of conduction. Conduction is improved. This is because your membrane voltage is depolarizing from its rest potential towards threshold for sodium channel activation. Okay? And so you have smaller distance in the voltage domain to go from where you are to threshold, and therefore conduction is enhanced up to a point. Once you reach greater depolarization, sodium channel starts to depolarize, to inactivate. So you start losing sodium channels, they inactivate. And as you continue to increase potassium, they inactivate more and more and more until finally, you fail. And for comparison, this is the simulated curves that Robin generated. Something happened.
Yeah, the mic went out. Maybe the battery. There's no battery yet.
Well, can you hear me without the microphone? Okay. Can you hear me?
But the Zoom people won't be able to.
Okay.
Yeah, they can hear.
I'll go ahead. We don't need. I'll scream. So with increasing potassium, you can see this known as the comma-shaped curve. It's a classic experiment. And you can compare the theoretical curves that Robin generated with the experimental ones, and you can see the nice correspondence between the two. The other way of obtaining slow conduction and compromising conduction is by decreasing the connection through gap junctions. Now the situation is very different, and that somehow could, at a first glance, seem very non-intuitive to you. See, what happens is if you look here, okay, the sodium channel availability is almost flat in this whole region here. Okay, almost no effect because we don't touch the sodium channel. We only change the gap junction. So that doesn't change much. But look what's happening to the rising phase of the action potential. It becomes more robust and faster, which is really counterintuitive in a way. And then, up to a point, once you increase the gap junction too much, then they both fall and conduction blocks. If you look at the curve on the left panel, this is the telling one, really. What you see here, you see a monotonic decrease in conduction velocity. But unlike the case of reduced excitability, okay, safety factor is not falling off together with the velocity. In fact, counterintuitively, it seems, it increases. And so conduction here, for example, will be much, much slower than normal, but also safer. So this is really a prescription for slow, sustained, safe conduction. It is a double-edged sword because it's used, for example, the AV node is making use of this. There is paucity of gap junctions in the AV node, and the AV node wants to have slow and safe conduction so that every bit is conducting to the ventricles, but provides enough time for ventricular filling. So you want slow conduction through the AV node, but safe. And this is slow, but safe. And the reason that it happens is that if you think about it, once you start isolate cells by increasing the gap junction resistance, you confine the charge to the cell in question. So all of this charge is available from the cell to depolarize. So it depolarizes very safely with a lot of charge. But then there is a long delay to cross to the next cell. So it's slow, but each cell is very safely depolarizing. And then transmission is slow up to a point. Once you reach very long delays, then during those delays, sodium channel inactivation occurs and conduction fails. But it fails at velocities of 1 centimeter per second, unlike the reduced excitability was 20. Very different story. And this is what's happening also in arithmetic substrates where you have uncoupling. Slow but safe conduction provides for macro reentry situation. This is just a comparison of the two. You can see here decreased coupling and increasing the safety factor up to a point. Here, the delay is so long that during the delay, sodium channel inactivate and there is abrupt block, but with very high preceded, but very high conduction safety. In contrast, for decreased excitability, you can see monotonic decrease in safety, and then block occurs at around 20 centimeters per second, which is not slow. Now, what is the charge that underlies which channel is responsible for conduction in all of those conditions? Well, when you have reduced excitability, and Robin did this for many levels of excitability, it is always the sodium channel that is responsible for the rising phase of the action. So it's all sodium channel based. Even when excitability is reduced and sodium channel availability is low, you still depend heavily on the sodium charge. In contrast, if you look at conduction with increased gap junction uncoupling, that's very interesting. Now, contribution of charge from sodium is also shared by contribution of charge from the L-type calcium channel. And why is that? Because remember, what's important is charge, not current. The L-type calcium current is 2 orders of magnitude smaller than the sodium channel current. But if you look at this action potential, for example, that's the plateau phase, it fires, and then it stays and receives depolarizing current until here you see the change in slope. This is the time or the instant of firing of the next cell downstream. So here is when the load on this cell is relieved. All this time, the plateau is held up there by L-type calcium current. So it's a small current, 2 orders of magnitude smaller, but this one lasts for half a millisecond or so, and this current here lasts for a very long time. So you integrate a small current over a long time, you get a lot of charge. So conduction in conditions of reduced coupling depends on the L-type calcium current. That's very important. And it could be even reversed. Here you see a situation where the sodium charge is smaller than the L-type calcium charge for conditions of highly reduced gap junction coupling. If that's true, then in a region where you have long delays from cell to cell, if you block calcium current, conduction should stop, should block. If it depends on calcium current, if you block the calcium current, then it should block conduction where you have long delays. So here is such a simulation that Robin did. You see here a fiber, okay, that have reduced gap junction coupling, but then here abruptly there is an increase in gap junction coupling. What it means is that this fiber is very well connected. So the cell here sees a lot of cells in front of it because there is low resistance. So, you see a long piece of membrane in front of you that you need to charge. So this becomes a large load on this depolarizing segment that is before the transition. So here you expect to have a very long delay in conduction, and indeed you do. Yeah, this is 35, 36. You can see here long delay between 35 and 36. And this whole time, the membrane voltage at the plateau is held by calcium current. So now Robin blocked the calcium current by 8 to 80%. And what you see is what we expected to have, which is block at the decremental conduction and low at the transition region. So at the transition region, where you have an increasing load, long conduction delay, a lot of the depolarizing charge comes from the LF calcium current. And if you reduce the LF calcium current, conduction fails exactly at that transition. And there is an experimental counterpart to this, again from University of Bern. And you can see here, okay, a control. This is one of those streets that Andre devised. And you have a fiber, and then it feeds into a fiber that is expanded, fiber with an expansion. So that provides a large load on this segment of the fiber, just like we did theoretically. And you can see that in this direction, conduction is normal under control condition. But when you give nifedipine, which is a calcium channel blocker, conduction fails. And it fails exactly at the transition region, just like the simulation, exactly the same. When you do it in the reverse, where the load is decreasing rather than increasing, nifedipine has no effect because there is no delay. So there is no dependence. It's all sodium current. Okay? That's really correspond. This thing is very, very corresponding one-to-one with the simulation. So to summarize this part of my talk, membrane excitability reduction, velocity is decreasing with safety factor decreasing, can support minimum conduction velocity of about 20 centimeters per second, which is not slow. It's dominated by sodium current. In contrast, when your gap junction coupling is reduced, velocity is reduced, but with increased safety factor. It can support minimum velocity of smaller than centimeter per second, very slow. Major contribution from SF calcium current due to long local delays. So this clinical implication is a possibility, theoretical possibility. So the calcium channel blocker can block micro reentry in according to the theory in scars. But you have to remember, giving calcium channel blockers is tricky. If you give high dose, you compromise membrane, you compromise cardiac mechanics and contraction and so on. So the clinical use is not as simple as the modeling, suggests. So in other words, membrane excitability reduction is a prescription for conduction block. And gap junction reduction in coupling is a prescription for slow conduction. Okay, so now I go to the next part of my talk, which is I'm asking, can abnormal conduction be detected in patients? I wanted to see, this whole theory, works in patients. That all applicable at all. And can we see abnormal conduction in patient non-invasively? Here comes non-invasive ECG imaging, ECGI, that we developed in the lab. And some work on this was also done here in Salt Lake City by Rob McLeod and others. And so non-invasive ECG, meaning ECGI for electrophysiologic satellite associated with SCAR. That's what I will show. Because, as I said, SCAR involves uncoupling of group of cell, involves that kind of conduction, that is discontinuous conduction across long gaps between highly connected cells. So, first of all, the signature, the electrophysiological signature, was debated for a long time. Mark Josephson and Andy Wheat. Andy Wheat was in Columbia and was among the people who created the post-MI healed myocardial infarction model in the dog, where you could see centimeter per second conductions and long delays and so on. But the debate was, are fractionated electrograms. So electrogram, looks like a single deflection. If you look at the ECG, it will fast. But there are electrograms that looks like this. You'll see them in a minute. They have fractionation. They have many deflections. Many people thought these were artifacts. But then Josephson and Witt did a very compelling experiment and showed in the dog, in fact, they all did a healed infarct in the dog. They showed that we conclude that fractionated electrograms that continuous electrical activity are real phenomena that result from an atomic substrate in which muscle fibers are separated by scar tissue to produce slow and non-uniform anisotropic conduction. In other words, low voltage fractionated electrograms and late potentials are the signature of a heterogeneous scar that contains islands of excitable myocardium, okay, e.g. post-myocardial infarction. So the question is, can we see those fractionated electrograms? So for that, this is the scheme of the ECGI procedure in our hands. There are several other places, but in our hands. We use 250 electrocardiograms on the torso, but back and forth. That is on the chest and on the back, 250 electrocardiogram, which gave us 250 electrocardiogram all around the torso. And if you pass a line one point in time, it will give you the potential distribution on the body surface at that instant of time. So that's the electrical information that we use. We also push the patient through a CT or MRI scan to obtain in the same frame of reference the electrode positions on the torso and the heart envelope, the epicardial surface of the heart. And we generate this patient-specific heart torso geometry that you see here. Then here came a lot of development of mathematical algorithms. We have a whole arsenal of different algorithms that we really tailor to use for a specific application. I cannot go into the details of it, but there is a whole arsenal of many different algorithms for computing potentials on the surface from here and here. Combined through these algorithms, you compute potentials on the heart, non-invasively. You can then at every point compute the electrogram locally. From those, you can obtain activation sequences and also repolarization pattern. Okay? That's the procedure. Now, here comes Salt Lake City. So, this is Bruno Tecardi. Bruno died in 2015, and Bruno was the head of the physiology department at the University of Parma in Italy. And they built their this tank torso in Italy. And the tank torso was shaped on a 10-year-old boy, the son of one of the technicians in the lab in Italy. And so that was the torso. And in the torso, he had a dog heart that was connected to the circulation of another dog. And this heart could beat for 5 hours and was very robust for all kinds of experimental interventions. You could measure potentials all around the heart surface and at the same time potentials all around the body surface. That was perfect for us because we take the body surface potentials, the input for our ECGI, compute potentials on the heart, which is what we are after, and compare it directly to the measured one. So it was a direct validation for us. Bruno then was convinced by Adelsco, who was the head of CVRTI, to move to Salt Lake City. He came to CVRTI and spent many years here. And Bruce Stedman, see here, who was a master technician, built a torso tank that you see here that was improvement over the one they had in Parma, Italy. And you can see this tank. I just saw it the other day. It's in one of the corridors in CVRTI something, but it's there on display. So we use that kind of data in many, we did many validation studies on all kinds of conditions, extensively. We produced the name for all kinds. So that was for validation. And Bruno and I became very close personal friends over the years of this association. So here are some results related to scars. So first of all, these are electrograms. The A, B, C are taken from, let me look at this, for example, G, H, and I. Okay, H, I, G are taken in the blue region, where the red region shows a region of scar. So you can see that away from the scar, the electrogram is a single deflection, very robust and large voltage. In contrast, if you look at D, which is at the heart of this, you can see multiple small deflections. This is the fractionated electrogram that I told you about. On a large scale, you can see it here. 1, 2, 3 deflections of low voltage. So what we did, we basically collected all of those fractionated electrograms, and that gave us the red region that you see. The red region here, therefore, we call the electrical scar. It's the electrophysiological substrate that produces those kind of electrograms that is associated with the scar. This is a patient post-myocardial infarction with the scar. And so, and you see the green, it's graded. It's not, there is no immediate transition from the center of the scar where you have all those very low voltages. It's graded, and you have what we call the scar electrical border zone in green. If that's true, and these are all electrograms associated with scar, then they should be in the scar. And you can see scars with gadolinium enhanced contrast and MRI. So we did those and compared the electrical and anatomical scars. And you can see it took some engineering work to co-register the CT images with the MRI images and so on. Young Wang in the lab, who was a great engineer, did this. And so you can see here a comparison. This is the anatomical scar from MRI, and this is the electrical scar from ECGI. And you can see a very nice correspondence. In fact, the electrical scar most of the time is somewhat larger than the anatomical scar because of the border zone. But you can see the correspondence between these two. And this just shows many other patients that shows more complex. Let's look at this, for example. Here is an anatomical scar, okay? And here is the electrical scar. And here is the anatomical scar, and here is the electrical scar. So you can tell that the correspondence is very good. In addition to low voltages and fractionated electrogram, there is another signature for the scars, and these are late potentials. Late potentials are shown here. These are deflections and potentials that appear after the main EKG deflection. They reflect slow conduction through the scar that lingers after the QRS is over. Remember, this is a very slow conduction. This continues, maybe 1 centimeter per second. It will linger on and be there after the main deflection is over. So these are called late potential. It's recorded in patients invasively. So we also look for late potentials. And so the last thing I wanted to show you one image of a reconstructed arrhythmia in the context of a scar. So this is an electrical scar with low voltages, okay, with a little higher voltages in between the islands of very low voltages that are shown in orange. The green is a little higher, but these are all low voltages. And from this region came many late potential recordings that we reconstructed non-invasively. We then caught a VTB, ventricular tachycardia beat, and reconstructed using ACGI the activation sequence. And you can see here a beautiful for us, not so beautiful on the patient, but you can see a double loop reentry loop. There is one loop, this direction, another loop in this direction, and there is a common pathway. And the common pathway goes through the scar and through this region that has many late potential recordings. So it's all very consistent. So I come to the end of my talk, but I have to give the last word to Weidman. And Silver Weidman, as I said, was really, in my mind, the father of modern electrophysiology. Silver Weidman mentored and trained directly many outstanding cardiac EP, like Andre Kleber and Robert Weingart, that I showed you some of their experiments. And besides them there, indirectly, he also, of course, mentored all of us who are in this field. And as Mark Twain said, and Silvio Weidman, with his incisive sense of humor, could have said, it is noble to teach oneself, but still nobler to teach others and less struggle. And then Weidman said, in one of his papers, he put this at the end of the paper, he said, electrophysiologists never die. They only depolarize. So this is my former home. And WashU, a beautiful building for biomedical engineering, really outstanding facility and a great university. And the people that didn't work, modeling conduction was mostly Robin, and there are a few others, Yang Wang, Pedro Diaz, who was before Robin, Yang Kuchera, Wen Kwan, Ching Sing Lu, all of them worked on the work that I showed on conduction. And the ECGI imaging that you saw here was done by Yang Wang, Zhongji Zheng, and Phil Kukulich, who cardiologist, whom some of you know because he started in my lab this whole idea of non-invasive ablation using radiation. So Phil was a fellow in my lab for 2 years. We then had this idea to use ECGI to pinpoint where you need to re-radiate with radiation. And this is now in progress, including a group here that is also doing work on that. So thank you very much.